women starting as early as 38 may not produce the same amount of progesterone as they did, let's say, in their 20s, and that even women who are having regular monthly periods may not actually ovulate every month. And if you don't ovulate, you don't make progesterone. So why is that a problem? So estrogen is like a fertilizer. It causes the grass to grow or a breast to grow and the lining of the uterus to grow and thicken. Progesterone's like the lawnmower. It halts, like it stops the lining from thickening and thins it out, and it also mitigates that cell division in the breast. So when cells divide rapidly, there's a higher risk of cancer because of mutations that can happen. So if the progesterone is going to slow that down, it actually is helpful. There are studies that show that women who have their periods in their 50s and whatnot actually have a higher risk of breast cancer. And so a lot of people think, oh, it's because they have hormones, that's why they have a higher risk, and therefore we shouldn't be giving women hormones and whatnot. But in fact, it's because they have unimposed estrogen, meaning they have high estrogen, not enough progesterone. They don't have that yin-yang.
Hey folks, it's Mike Mutzel here with HighIntensityHealth.com. Thanks for tuning back into another episode. I'm very excited today to be with Dr. Shari Caplan. We're going to talk all about hormones, focus a lot on how you can reduce your risk of breast cancer, heart disease, stroke, and what you should know about progesterone and progesterone levels associated with aging, testing different hormone delivery systems, topical versus oral. And for men, we're going to address testosterone replacement therapy as well. Creams versus injectables. We're going to cover all those bases. So Dr. Caplan, thanks for coming on the show.
Thank you. Thanks for having me.
So Dr. Caplan, I think what's really unique about your practice is you really focus on the lifestyle. The top floor of your clinic, a beautiful clinic by the way, is really focusing on exercise and cooking, teaching people how to cook, and then below you really incorporate some of the stress reduction modalities, and the floor that we're on now is all about the medical aspect and balancing hormones and so forth. So I think let's kind of launch there with how lifestyle affects hormones. A lot of people think that they'll work on their lifestyle stuff after they address their hormones, but you're really like, no, we have to address the fundamentals first. So kind of give us the backstory on that.
A lot of clients who come into our practice, they kind of come for different reasons. Some come because they feel that they have hormonal issues, and that's what they really want to address. Other people feel they have other medical problems but may have a hormonal basis or whatnot. But what we kind of do is when they come in, we're assessing not just their hormones but their nutritional status and their stress levels. We sort of talk about everything, because essentially what I found is hormones don't work in isolation. It's like what we eat, how we sleep, what our stress is like, what's our toxic load, what's our, are we deficient in certain nutrients? And basically people will get much better success at feeling better if we not only are balancing their hormones, but also addressing all of those other issues. And, basically patients would come in and talk to me, and I would, obviously work on their hormones, but oh, by the way, you need B vitamins, or you're deficient in magnesium, or your vitamin D is not great. And there's clients who just give me the hormones. I don't want to know about not eating gluten. I don't want to know about changing my diet or doing anything else. And they will feel better, but they can feel even, have much better success if they actually kind of addressed all the problems. And so, I would tell them what to do, but again, I didn't have the services to offer them all these things. So my husband was like, let's just put it all in one roof. And conceptually that made great sense, but when we decided to do that, it was a lot of work.
Yeah.
But essentially, yes, so that's where we, getting people to move, whatever form it is, whether it's yoga, dance, Pilates, we want them doing something because that actually changes telomeres and modifies our genes. We want to do stress reduction, so exercise is a good method of stress reduction, but we also have meditation classes, and we actually have individual therapy for people to deal with their stress. We want to teach them how to eat right, and so we have cooking classes, we have cooking demos, and we also have an opportunity to do patient education. So clients can come in and learn on so many different topics to help themselves. And then also, like on the lower level, we have our detox de-stress floor. So we have massage therapy. Again, we have different rooms for meditation. We have infrared saunas. So it's about, you know, taking care of ourselves. And then on our main floor, which is more of the medical, we have sort of you know, the hormone therapists. We have chiropractors. We have naturopaths. We do IV therapy. And we have a great weight loss program.
Yeah.
So so we try to you know, help people in many different ways. But really, I think what sets our clinic apart from a lot of other doctors who do hormones is, you know, it's much more than just hormones. Hormones is like this
Small
in
piece.
Comparison to everything else. So.
Yeah. Now, since opening this new clinic with all these different modalities and lifestyle factors kind of woven in, have you found that the buy-in for patients when you tell them you need to meditate or you need to do exercise, it's not just about jumping into the hormones? Have you found that buy-in's a little better because you have it all under one roof, or?
I think that it's much easier for them to buy in because they're like, oh, look, I can do it all in one place. Or I don't have to seek out a place that's going to offer a program that's kind of good quality. So, you know, I'm a bit of a neurotic nut case, and I always want to make sure that, you know, we're providing good quality services. So I think when I sort of say now, at least go do this, this, and this, that they're more likely, although some of our clients are coming from far, so then they don't get that full benefit. But then I say, come in for a day spa, you know, come in, do a meditation, do a yoga class, see your practitioner, we'll, you know, feed you, and off you go and have a great day.
Kind of like an immersion, if you will, a retreat. That's a really nice approach. So let's go back a little bit, because you haven't always had all this under one roof, right? And so when you first probably started recommending hormones to people, balancing progesterone and what have you, folks that weren't addressing the lifestyle factors, the stress reduction, sleep improvement, diet, and so forth, how effective, I mean, you said a little bit earlier that hormones will help, but they don't really get you the full way. So kind of talk about like why this is really needed, you know, this lifestyle component.
I think we actually have to step back even a little bit further. So basically, a lot of people are having hormonal balances partly because of our environment. And so basically, let's talk first about women, and then we can talk about men. But essentially in women, you know, they're the main hormones, but there's many hormones that actually play into this, is estrogen and progesterone. And so our environment now has so many fake estrogens around called xenoestrogens, and they also happen to be endocrine disruptors, that basically instead of things being in balance, all of a sudden we have way more estrogen load and not enough progesterone. And that sort of causes women to have a lot of cycling issues, and we have receptors for estrogen and progesterone throughout the body. And so when women have way more estrogen relative to progesterone, they're moody, they're irritable, they have weight gain, and the list goes on. And you know, so one is, you know, you can sort of say, okay, well, I can balance your hormones by giving you more progesterone. But really, what about going the opposite direction and saying, how do we reduce all those excess estrogens? So that may be through diet. So herbicides and pesticides look like estrogen. So if we ate a little more organic, if we, you know, didn't eat out of plastic, you know, containers and heat things up in the microwave in plastic, if we sort of detoxified more, because we do use our estrogen, but if you don't have good gut bacteria, what happens is you use it and you keep reusing it, where you want to use it and get rid of it. So there's so many different ways to cause hormonal balance, not just about giving you hormones. So you can either take away the excess or you can improve the progesterone. But even still, that estrogen progesterone balance causes a whole bunch different problems. And let's talk, how does stress affect our hormones? Well, in the hormone cascade, it starts from cholesterol, but then progesterone, and progesterone makes cortisol. So if you're stressed out, you're going to steal all your progesterone to make cortisol. And so even if I give you progesterone, and if you haven't dealt with that stress component, all you're doing is you keep shoveling it down to cortisol, and then you're going to be tired, wired, and fat. So if I can get you to meditate and, you know, learn to say no, or all these other skills, then at least, you know, your estrogen progesterone balance will be better. And if I give you progesterone, you're likely to keep it there. So that's kind of one way to sort of look at the estrogen progesterone balance, but also like if you're deficient on certain nutrients, then again, you're not going to make your hormones well, you're not going to metabolize them well, so it's kind of, a lot of people will get better with standard hormone replacement, but if you're not addressing all those other baskets, then chances are you're going to be in the office complaining about some other problem down the road.
Or something more serious, potentially like cancer and so forth from the...
Correct.
Yeah.
Right.
So as a clinician, just to go back, so that you mentioned, the toxic burden, right? The synthetic estrogens in our environment, which are so ubiquitous in couches and flame retardants everywhere, brominated compounds. But I'm interested because you picked that first out of all the factors. So as a clinician, you feel that that's a big issue, you find?
Yeah, I think it is. I guess I used to do a lot of obstetrics, and I used to lecture to medical students and residents about neurotoxins that we measure in cord blood and in breast milk. And when I first started lecturing, it was around 200, and then next thing I know, it's like 374. Yeah. So in Canada and in the US, there's a lot of biomonitoring about toxins. So it's not something that the naturopathic clinic made up or whatnot. It's a true environmental issue. And what I've learned is I actually have genetics in my detoxification. Wow. And so I actually am missing glutathione S-transferase enzyme, or GSTT1. So I don't detoxify well, and so a lot of people can take NAC and make glutathione, and I had elevated mercury levels and took NAC for years thinking I'm doing this wonderful job in detoxifying, and lo and behold, I did my genetic testing and found that I was missing this enzyme, and I started taking glutathione, and then all of a sudden my weight was easier to manage, and I started feeling a whole bit better, and then it kind of made me think, gee, I think that, one is we're exposed to a lot of toxins, and then I see a lot of clients who aren't feeling well, and I'm done everything already, and like, what am I missing? Yeah. And then when I kind of add in that detox pathway, how do we upregulate it, make it more efficient, people start feeling better, and weight actually was improved. So, I always laugh that a lot of my patients, they come in for kind of the wellness or hormone, and they're kind of concerned about the fees they have to pay. But anytime that I talk about weight loss, it's like, sign me up. I don't care how much it costs. Mm-hmm. But, so through our weight loss program, we sort of address all those lifestyle, nutrition, supplements, and, it's a great weight loss program. But on top of that, we always talk about detoxification and hormonal balance.
That's huge. And so if we could take a deep dive into what you recommend. So NAC and sulforaphane, probably other B vitamins and so on, but you also have saunas here as well.
Correct.
So how big was that part of your therapy too, sauna?
So
therapy?
Again, because the clinic is, fairly new, but yes, so we want to incorporate the detox saunas as part of it, because again, actually just to step back again, is that what we've seen is a lot of people, when they start losing weight, their CRP starts elevating. And my theory on that is that we're liberating a lot of toxins. And again, if those detox pathways aren't open, or we're not getting them out, all we're doing is recirculating these toxins and basically self-sabotage, because what does the body do? It says, oh, I need more fat to neutralize these toxins, right, and tell you to eat. So if we work on getting those toxins out, so through supplement or infrared saunas, exercise, whatnot, then we have a higher likelihood that you are going to keep your weight off and you're going to be more successful.
Right, and you mentioned the microbiome earlier, and so that's a huge point. Like you mentioned, how the hormones can be recirculated. And right, we also know that toxins can be recirculated too. So are you into high fiber and stuff? I know different practitioners like different diets, and just personally
Well,
curious.
I think basically one of the components are, yes, we need a good fiber, and then, but everybody's sensitive to different, we can't use the same fiber for everybody. Some people, certain fibers actually irritate their bowels, and so it's kind of finding the right mix for them. I try to use more things that have to do with balancing the gut bacteria, prebiotics, only once the gut is doing well, because we don't want to feed bad bacteria as well. Kind of using sort of more stuff on larch that will also work on the immune system. Cool. Like there's a whole list of stuff that we like to use to sort of help balance that gut microbiome, because also there's studies showing, that if you have more firmicutes or bacteroides, that in itself will cause people either to be overweight or metabolically active and causing weight gain versus not.
Yeah.
So, we haven't got into poop transfers, but my husband's this tall, skinny thing that, he eats like tons and, loses weight overnight. So
he'd be a good donor.
Yeah, he would be a great donor.
That's really funny.
Let's just talk a little bit back to estrogen progesterone balance and why it's also a problem, right? So basically a lot of women, when their estrogen progesterone is off whack, they tend to have very heavy periods. It can cause them to be anemic, and also when people are low iron, it blocks their thyroid, and when their thyroid's blocked, they get more heavy periods, becomes a catch-22, basically other things like I sort of rely on a lot of work by Dr. Geraldine Pryor, who's an endocrinologist at the University of British Columbia, and she's sort of studied women's cycles at the yin yang, where she had them pee into a cup every day of the month. And what she noticed is women starting as early as 38 may not produce the same amount of progesterone as they did, let's say, in their 20s, and that even women who are having regular monthly periods may not actually ovulate it every month. And if you don't ovulate, you don't make progesterone. So why is that a problem? So estrogen is like a fertilizer. It causes the grass to grow, or our breasts to grow, and the lining of the uterus to grow and thicken. Progesterone's like the lawnmower. It halts, like it stops the lining from thickening and thins it out. And it also mitigates that cell division in the breast. So when cells divide rapidly, there's a higher risk of cancer because of mutations that can happen. So if the progesterone is going to slow that down, it actually is helpful. And so what she has shown is women 38 and on may not produce the same amount of progesterone, and therefore may have a slight higher risk of breast cancer because of it. And also women, there's studies that show that women who have their periods in their 50s and whatnot actually have a higher risk of breast cancer. And so a lot of people think, oh, it's because they have hormones, that's why they have a higher risk, and therefore we shouldn't be giving women hormones and whatnot. But in fact, it's because they have unimposed estrogen, meaning they have high estrogen, not enough progesterone. They don't have that yin-yang. So actually, by giving progesterone, it may actually reduce their risk of breast cancer. But that's natural progesterone and not MPA, which was in the WHI study, because those two drugs are very different. So progesterone is what we make every month when we have our, in our cycles, and what we make in pregnancy, and is quite breast protective. Whereas MPA is a medication that is an altered molecule. It's not something that our body recognizes. It works very similar to progesterone, the lining of the uterus, to prevent estrogen stimulation, but actually can increase women's risk of breast cancer, and that's what the WHI showed. So that's where I think most doctors and patients are very nervous about using hormones, because there's all this huge study that showed if you use the drugs that were in the study were Premarin and Provera, that if you use those drugs, it increases your risk of breast cancer, and that also increased the risk of stroke. So there's a lot of things we've learned from that study, and basically, if we're going to take an estrogen, we're not trying to swallow it, because when you swallow estrogen, it increases clotting factors and increase that risk of stroke and cardiovascular event. If we give estrogen through the skin, it doesn't do that, so it has less risk. If we have a choice, which there's no reason that people don't have a choice, that we should be giving progesterone as opposed to methoxyprogesterone acetate. Yeah, so.
Really interesting. What's kind of shocking about those studies that you mentioned, if you actually read the abstract, even though they use progestin. I haven't looked at this in a little while, but they'll say in the abstract, like they'll mention progesterone, but they're using the synthetic.
Progestin, right.
So it's
and
confusing.
so it's like the medical community somehow mixes up progestins, progesterone, and progestogens, which is the group of progesterone and progestins.
Yeah.
And it's funny that two things. One is there was a large study in Europe that actually showed, depending on which form, progesterone or progestogen, that you used, your risk of breast cancer was different. So yes, if you use medroxyprogesterone acetate, your risk of breast cancer was 1.6 relative risk increase, whereas if you used progesterone, it was 1. So there's a difference. 2 is no OBGYN would ever give a pregnant woman MPA. Why? Because they know it causes cleft lip and palate, but every person who walks through a fertility clinic will get progesterone. How is it that they know the difference for pregnancy, but then kind of lose it for everybody else?
Wow, I didn't know that. That's really interesting.
Yeah.
So it must affect methylation then at some level. I mean, possibly at that.
Put it this way, it's a very different drug. And if you actually looked at a molecule of estrogen and a molecule of testosterone, they look more similar than progesterone and MPA. So it's how did they think they were going to act the same? Yeah. They act the same or similar at the lining of the uterus, but they act opposite everywhere else.
Right. So for people that are kind of new to the biochemistry, so they stimulate the progesterone receptors. We're talking MPA or progestin, but molecularly they're totally different, and that's why.
Correct. But they only stimulate the receptors or act similarly at the lining of the uterus. Oh. But in the brain and in the heart, like we have receptors for progesterone and estrogen throughout our whole body. Mm-hmm. And the adage that if a woman's had a hysterectomy, she doesn't need progesterone, because again, in conventional medicine, the only reason to give progesterone is to block the estrogen stimulation at the lining of the uterus, because we don't want to cause endometrial hyperplasia or cancer, because high estrogen with no progesterone causes that to happen.
Sure.
So if we give progesterone, it halts it, but because women have receptors throughout our body, giving progesterone makes a world of difference for those women.
Right.
So, progesterone is actually, it binds to the GABA receptor, which is our, when you take Ativan or benzodiazepine, it binds to that. So it makes you nice and calm. So one of the first hormones that women start losing is their progesterone, and all of a sudden they start having sleep problems and anxiety. Well, why don't just give them back their progesterone, and all of a sudden they'll be more calm and less irritable and sleep better, as opposed to a sleeping pill or an antidepressant that most of my colleagues are now giving to perimenopausal women, because that's the symptoms that they're presenting with.
Right. And that's what I love about your approach is a lot of people in the natural medicine community are if someone has sleep issues or anxiety, they jump to GABA, theanine, and those are effective, but you're like, well, let's really look at the body and see what your age is. Look at, did you stop menstruating, or did you have really light periods and other symptoms like anxiety? Because I think, balancing natural hormones is a huge piece of the puzzle. I have a lot of friends that in your similar shoes, that will tell me that, it's really hard to age gracefully without the hormones, right? And so I love that. Whereas, people like kind of the crunchy tree hugger types are really against that. But really it's like, I think it's better life through chemistry, obviously mitigating your risk. But so some of those symptoms, just to summarize for people, of low progesterone, let's kind of talk about that a little bit, in the late 30s and 40s. Menstrual cycle.
So they can have irregular menstrual cycles, really heavy flow and flooding and clotting. Some women, when they actually have high estrogen, no progesterone, they actually have no cycles. So anything and everything can happen with regard to women's cycles, but they can be moody, irritable, PMS, weight gain, people cause bloating. A lot of perimenopause women have palpitations, so it even affects the QRS, or the electrical impulse of the heart. Wow. So it's like integral into everything. So, almost any diagnosis can be a hormonal balance, but it doesn't mean that is the answer. It just means, okay, let's go back to the biochemistry. What does this look like? Is it a hormonal imbalance? Is it a nutrient deficiency? Again, sometimes if your nutrients are deficient, you're not going to make those hormones. So if we can fix that, or if we can, when you're stressed out, you cut out the hypothalamic pituitary axis. So you're not going to make your sex hormones and whatnot. And is it that we give you your hormones and not address the stress? Well, it'll work, but it's not getting at the root cause. If you want to get at the root cause, you want to sort of address that stress component, get that person, meditating, feeling better, and their hormones are going to come back. So there's many ways to skin a cat. I am very fortunate that I, can dip my hand in the naturopathic or lifestyle basket, or I can dip my hand in the prescription medicines as well. And I've been sort of practicing medicine for over 25 years, and I have to say, treating patients, especially with hormonal issues, is not an easy thing. And there's days where I scratch my head and I go, oh my God. There's a lot of practitioners out there, unfortunately, who get like a 1-day or a weekend course, and then they hang up their shingle and say, I can do bioidentical hormones. I think, you have to find the right practitioner. You want to connect with someone. You want to do it in the right way and the safe way, because hormones are still hormones and there are risks. And so I'm not going to say to anybody, there's no risk taking hormones. There's risks if you cross the street. We have to choose that we want to cross the street. Right. And I guess a lot of people say, bioidentical hormones are safer. So I would sort of say, yes, they're safer than other choices, but everything we do in life is a risk-benefit ratio. I think for progesterone, I would say 95% of people benefit from it, and it helps maybe reduce their risk, especially if they have unopposed estrogen. But there are a few people who can take that progesterone and make an estrogen-like molecule. So we are all individuals, and we all have genetics that are different, and we all have to sort of figure things out for ourselves. Obviously, with the practitioner is helpful. Yeah. I think the other thing is, a lot of women can get into bleeding problems, and if you're not prescribing sufficient progesterone with an estrogen, that the lining of the uterus can get thickened. And so you need someone who can, mitigate that risk, but also if there's a problem, be able to investigate it as well.
So that's where like the biest or the triest would come in to help with that?
So
that combination?
Well, basically, so many years ago, we used to use triest. So triest means 3 estrogens, and so there's different estrogens. There's actually way more than 3, but those are the 3 that people talk about. So there's estradiol, which is what we make all the time throughout our reproductive life, but once we hit menopause, that gets less and less. There's estriol, which we take our estradiol and metabolize. There's studies showing that women who make the highest estriol in pregnancy have the lowest risk of breast cancer. So a lot of times practitioners would add estriol to their hormones. And then estrone was that 3rd estrogen, but it ends up, it's kind of breast cancer permissive. It kind of stimulates the breast cells to divide more. So when they used triest, it was the estriol, estradiol, and estrone all together, because that's what the body made. So they said, let's replace the way the body made it. Now they've kind of like, okay, we don't want any estrone. And in fact, Premarin, which was part of the WH study, looks like an estrone, and estrone is more likely to cause DNA damage. We'll talk about that after. Sure. But essentially, so triest has fallen out the window and shouldn't be used. So some bioidentical hormone practitioners will prescribe biest, which means 2 estrogens. So it'll be estradiol and estriol. Or I will use a biest, or I'll just use straight estradiol. Why? Because I'm going to work on all those pathways to make sure you're converting your estradiol to estriol anyways. And we convert 70% of it anyways. So
I see.
I'll use that. So that's the estrogen part, and then progesterone I'll use progesterone, whether it's a pill, a cream, or whatnot. But when you're using cream, again, my colleagues don't believe that cream works. I can tell you that I've had women who are on disability and perimenopause suffering, and I gave them cream, and they put a little dollop every night, and they come back 1 to 3 months later, and they're like, how is that one little dollop of cream makes such a world of difference? I'm sleeping, I'm less anxious. So I know it works. And then there's a few studies that show 20 to 30 milligrams of progesterone cream will protect the lining of the uterus. So, but again, how we all absorb and metabolize is different. So you can never be 100% what the exact dose is, but that's why you may want to, if someone's using progesterone cream, is maybe have a pelvic ultrasound or some investigation every 1 to 2 years. And especially if they have bleeding after not having bleeding for a while, that they need to be investigated.
Interesting. But are those same, do you need to do those investigations, I should say, if they're taking oral progesterone? Or not as much?
Again, if someone presents with bleeding who hasn't had bleeding and they've been on hormones longer than 6 months, because usually when you start, there can be different bleeding patterns. But if they've been on it and they've been stable and then they start bleeding, you probably need to investigate. Unless, of course, there's still that perimenopause range, right? So perimenopause, like anything and everything can happen. So the definition of menopause is 1 year without a period. So if they were someone who was maybe having a period every 3 months or every 6 months, and so, they had a period 6 months ago, they've been on hormones for 6 months, and then they bled again, you might sort of say, well, they still haven't reached menopause. But again, it's a conversation to have with the client. Do you want me to do the investigations? Do you want to hold off? And, so I work with the patients and come up to a treatment plan that we both agree on.
That's awesome. What's interesting about the oral progesterone is the anxiolytic effect. You hit on the GABA receptors and even the heart palpitations. I didn't know about that. But does the oral progesterone also confer protective benefit, I guess, against breast cancer and heart disease as well? Or is it just more the topical?
No, so they do the same. It's the same molecule whether you're swallowing it or putting it on topically. It has to do with the absorption. So what happens is, an example, like progesterone that comes in the pill form is usually 100 milligrams. So when you swallow progesterone, a lot of it gets converted to allopregnanolone, which does really help with sleep. And then the rest stays as progesterone. So I would sort of say out of that 100 milligrams, they're probably absorbing 10 to 20 milligrams of progesterone. When you do it topically, if we're applying 20 to 30 milligrams, their belief is that most of it's absorbed. It's just the matter of when. And so, it's not bypassing the liver and it's not getting degraded. So that's why the dosing could be a little bit different. Some women love the pills. It's convenient, it's easy, they can get it at any pharmacy if they wanted to. But some people get bloated or they get gut issues or whatnot. And again, if someone's gut is poor, they're not going to absorb their medication the same way that someone has an integrated, a gut that's working well.
Right.
So again, it's trial and error. Some women don't tolerate oral and they love the cream, or they've used the cream and they go, did nothing for me, and they switched to the oral. It's all trial and error.
Yeah.
So estrogen we don't want to swallow orally. Progesterone is fine. And so again, some people will say that progesterone it works better for sleep when it's given orally. I think it's true, but even topically, women will find improved sleep.
Yeah.
And I always tell the little story about my son who, we were on vacation together, we were sleeping in one room, he was 16, and he was wired and he couldn't sleep. And I'm like, I need to go to sleep. So I gave him a little bit of progesterone cream. And then he woke up in the morning, he was like, Mom, that was the best sleep ever. Can I use that every day? And I was like, no.
Yeah. What would be the complications associated with that?
Well, actually, there's a lot of practitioners who actually give progesterone to men because, again, we all have the same hormones. It's just how much. So, I usually say that we can give men lower doses of progesterone. So, again, swallowing a pill, probably somewhere between 10 to 30 milligrams, where women we give somewhere between 100 and 300. But too much progesterone for men can actually cause erectile dysfunction. So we don't want that. I always joke with my patients also, because sometimes they'll put progesterone in the private area, and I sort of say, you know, if you happen to put it on, your husband starts up with you, don't worry about it, he'll just be nicer afterwards. Because it causes, binds to the GABA receptor, so you feel calmer and more relaxed.
Right, that's very interesting. So not so much for men, low doses, but if anything, it would be oral, because that conversion to the allopregnanolone, right?
Yeah, you can actually use it. So again, a lot of practitioners who actually give testosterone might give a low dose progesterone we're talking about testosterone cream, a low dose progesterone. Why? Because it blocks it from going to dihydrotestosterone, which causes some of the side effects.
Interesting. That's a really good tip. I've never heard that before.
Yeah,
awesome.
Well, there's a lot of tricks up my sleeve.
Yeah, that's fantastic. One of the things that I wanted to talk to you a little bit about is, this goes back a little bit to our discussion on the endocrine disrupting chemicals. When I travel a lot, Dr. Caplan, and I stay in Airbnbs or people's homes, and the bed sheets have a lot of fragrances and shower products. I mean, all of them are just like traditional stuff from Walgreens or Walmart or wherever, with all the parabens and perfumes.
Right.
So I know that's a big part for women, right? Because a lot of women put on makeup and use these cleaning products. How big of a part, in your therapy, of all the things that you...
I think, again, clients, again, each one is genetically different, so some might be able to metabolize it and it's not a problem. Others, like even the smallest amount of fragrance or whatnot, is going to cause a problem for them. So again, my protocol would be to always have someone on B vitamins, which help with methylation, and if they kind of have certain things in their history, I might improve their detox pathway, whether it's NAC or some other product that's going to upregulate phase 2. Mind body is huge too. So if you kind of go into a room and it's like, holy Toledo's, there's all these bad things for me, and this doom and gloom, then likely you're going to have a worse outcome. Whereas if you're like, well, I'm doing the best I can, when I have my opportunity, I'm going to live cleaner, but, there's situations where I can't control and it is what it is, likely you're going to be fine, right? I mean, if we actually looked at all the all the toxins in our environment, it would be like, oh my God, I might as well kill myself because I'm going to die anyways, but, it's,
You got to deal with it.
Yeah, because when you start doing environmental medicine, it's like, oh my God, it's like, you can't do this, you can't do that, you shouldn't, eat fish, don't eat fish, Even
the air, I'm hearing the air as we're talking right now, and then you start to think oh my gosh, it's recirculating these compounds from outgassing and, compounds from the tile and building products.
Right.
But yeah, like you said, so you have to have an open mindset and really just control what you can.
Right.
Not be too neurotic about it. Yeah, that's really good. But I do see that with women, though, a lot, the shampoos and cleaning products. So
ideally, if they can buy products that are paraben-free or fragrance-free or whatnot, or use more essential oils, there's so many ways to, avoid, but it takes a lot of work, and it could be almost a full-time job, researching every product and whatnot. But hopefully the government with time is starting to, and I think also companies are kind of realizing that the consumer has the last say, because whether they're going to buy their product or not. So I think there is a shift to sort of avoid some of those things. And it's not only women that have that problem, because men also. So basically what we see is, because I also worked at a fertility clinic, is that younger and younger men are coming in with lower testosterone levels. The gold standard used to be 100 million sperm. Now it's good enough you have 20 million sperm. Wow. And that's a huge difference in not a long period of time. And so what happens is, when you have way more estrogen than testosterone, it actually causes a lot of problems with fertility, also they tend to gain more fat. They aromatize their testosterone to estrogen, so they actually have low testosterone as well.
So you're seeing this in mid-20s or early 30s?
I would say starting in their 30s. Yeah. So it's pretty sad, and it's interesting, because when you work at the fertility clinic, it's kind of a marker of aging in a sense as well. I'll have people come in who are having difficulty, and you look at them and, they say they're 30 and they kind of look 45. Like, so I think our environment and, you know, the way we eat and do all these things is aging us, and that has repercussions on our fertility.
Yeah, as a kind of a side note, I've noticed in Ontario, people generally look younger outside of the city. I noticed that. I was in Elmira and St. Jacobs and these different smaller towns where there's the Mennonites, you know, and a lot of local food, and some of the practitioners that I meet with just look amazing. They're in their late 60s and 50s and they look like they're 30. So it's really interesting, like you mentioned, that stress and the hustle and the artificial light. There's so many factors there. But to get back a little bit, because I know we have a lot of men that listen to the podcast and want to know like what to do for low T, you know, because I don't think the solution is just to jump on testosterone as like a first, you know, approach, right? What did you find, really, I guess, for testosterone and then for fertility? I know there's coenzyme Q10 and a couple of different things.
Right. So, well, one is there are certain supplements that you can take to increase your sperm count. So again, they're a good antioxidant. So like you said, CoQ10, NAC actually has a lot of studies. So NAC, N-acetylcysteine, which makes glutathione, which helps with detoxification, which basically is a good antioxidant, but also helps get rid of some of these toxins, actually improves sperm count. But it also detoxes estrogen. So, so that's kind of an interesting. And if you actually look in the workout world, like, you know, they're talking about DIM now, right? So what does DIM do? It helps with estrogen detox. So it's all about getting rid of that excess estrogen so testosterone can start happening. So in the feedback loop, again, if you have high estrogen, it blocks testosterone production as well. And also then there's other things. If you happen to be on the heavier side, you take your testosterone and you make estrogen. So it becomes a vicious cycle. So again, and also stress. What did I say? The stress cuts off the brain's messages to the testicles to say, make testosterone and make sperm. So if you're stressed out, again, stress reduction, and again, nutrient deficiencies. So I think low zinc, low B vitamins also deal with, and low folic acid also has to do with sperm production. So everything that I say about things for women apply to men. So eat right, exercise, de-stress, take your supplements, and you know, specifically for low T, so zinc are very good, helpful, because again, it blocks testosterone going to estrogen. Then there's the DIM that we talked about. So again, it helps with estrogen metabolism, so it helps get rid of excess estrogen. So again, it helps. And then there's a whole bunch of herbs that people will use, tribulus and whatnot, to raise testosterone naturally. And then you get into, you know, a lot of people had traumatic brain or don't even know they had it, because to them it was no big deals. They were playing sports, they got whacked in the head and whatnot. So there's actually a lot of reasons why people who are younger may actually have low testosterone. And it's not just about giving them the low testosterone back. It's maybe like looking at what else may be off, because there may be other hormones that are affected because of it, so that that person, not just for fertility reasons, but longevity, right? So if you're low T at 30, then you're having, you know, increased cardiovascular risk, you have increased diabetes risks, there's a whole bunch of other risks associated with it.
Right, bone loss and other things. Yeah, it's pretty interesting. We caught up with a physician friend of mine, Fred Grover. He does a lot of neurofeedback and biofeedback and works with football players, a lot of the ex-Denver Broncos, and that's a huge part of his therapy. Dr. Caplan is this hypothalamus getting, he called it the coup counter coup,
right?
And then he sees the hormones drop, and then so he does a couple things like ECG actually and a few others. So folks want to check that out, they can click the link below this video. But let's finish off with men a little bit. So we have injectables, topicals.
Right, for testosterone.
Right.
So my preference is to give testosterone injections. Why? It's cheap. I can easily measure it in the blood, and I kind of know what I'm getting. And you get very quick responses to sort of see if it's going to work or not work. Creams, like again, what does a man make in a day? 7 to 10 milligrams of testosterone a day. But the prescriptions that are being written is for testosterone between 50 and 150 to 200 milligrams of cream a day. Why?
It's a lot.
Women, I don't give them that much whopping dose topically. So it's sort of like, I wonder what's going on, why it's not absorbed or whatnot. And again, practitioners are looking, when you give topical testosterone, to look at the blood levels. But again, when we give creams through the skin, I think it goes to the tissues first and then into the blood. So if we kind of have really good blood levels, I think we're probably overshooting. And then it's going down different pathways. So you might get more dihydrotestosterone and causing hair loss and acne, or prostate issues, or more estrone or estradiol, which can cause weight gain and also prostate issues. And so it's kind of finding that sweet spot. So for me, I like the injections better, but some people just don't like doing the injections. And so I work with whatever they want to work with.
Yeah, what I've read and practitioners that I've talked to, the argument is the topicals really mimic their body's circadian rhythm. So you can do the topicals in the morning and so forth, but like you mentioned, you're doing 10 times more than the body actually makes. So like, yeah, it's super physiologic, even though, yeah, theoretically you're in line with the circadian rhythm. But I do hear a lot of practitioners say, like, if you want good results, just go injectables, even though it's invasive and what have you. But
now we're doing also sub-Q injections, so less painful, easier, lower dose, and so like, when there's a will, there's a way, and whatever works is the bottom line, because we're all individuals and we all have preferences, and I might say do it this way, and if they're not going to do it, what's the point?
Right. And then with sub-Q, so subcutaneous, and you talked about how fat cells kind of aromatize testosterone to estrogen, so your overweight men tend to have higher levels of estrogen relative to testosterone. With the sub-Q injections, do you see that, or it's
no? I actually don't, because like where we're injecting it, I'm not injecting it into their fatty areas, right? I'll still pick an area that has minimal sub-Q fat. So it's just somehow the absorption just seems to work better. And so they seem to have, let's say someone's on 80 milligrams a week or whatever, with sub-Q, I find we can actually maybe get away with 70.
Wow.
So it's kind of neat. So you can save money again that way too.
Absolutely. That's really awesome. So we have a few final questions, but I know you want to talk a little bit about insulin, leptin, and cortisol. I know we talked about the HPA axis and how all this is connected. Anything that we didn't address yet about those three hormones that you want to talk about?
Well, they're all intimately connected, and that all those hormones essentially can cause people to be fat, tired, and whatnot. So insulin resistance is huge. We're seeing kids in their 20s already starting to show signs of insulin resistance. It's crazy. I think, again, the way we eat, that we have nutrient deficiencies that kind of increase insulin resistance, and as we age we have insulin resistance and so many other things that contribute to it. And in our weight loss program, we always try to address that. So we try to give them a diet that's low glycemic index, good proteins, good fats, and to help with reducing insulin, because insulin's a growth factor and makes you fat. So that's one thing. Also, when you eat a lot of carbs, that people tend to, the hormone leptin, which is supposed to be released from your fat cells, go to your brain and said, you don't have enough energy on board, you don't need any more. Because when you eat carbs, that message gets blocked. Also, if you have high inflammation, high CRP, the CRP molecule will prevent leptin from binding in the brain. So you lose your message about your calorie content in your body or your caloric needs. And so people are hungry and they're eating. So we will again do things to help reduce leptin, or what we call leptin resistance. So it's about not, having enough to work, but not having so much that the body ignores it. And basically, again, cortisol plays into both of those things. So if you have really high cortisol, you're more likely to gain weight in the abdomen area. It messes up all the other hormones. And again, inflammation ties into insulin resistance and leptin and cortisol. So.
Right. So that's why, again, you really underscore the importance of lifestyle change and put this all under one roof, so people are managing their stress, they're detoxing, they're exercising, eating clean, low glycemic index foods, and so on.
Right.
Beautiful. That's fantastic. Well, we have a few final questions, Dr. Caplan, that we've asked every guest on the podcast. The first one is really about your morning routine. So I know you have, I think, 4 boys.
I have 3 boys.
3 boys.
And 2 dogs. No.
Yeah. Husband, busy practice. Again, one of the most amazing clinics that I've been in. I've done this a long time, so this is a beautiful clinic.
Thank you.
I know you're super busy, and you need to work on your own stress and your own health and stuff like that. So what do you do in the morning? What does your first couple hours of your day look like?
So Because what happens, I tend to work more later in the evening. I actually sleep in the morning and get my Z's, and then basically get ready and start my work. Through building this clinic, I had to sort of heed my own advice, and so I've learned about meditation, and my husband and I sort of do a meditation practice. I'm lucky enough that I have exercise in my own building and meditation and saunas and whatnot, so at the end of the day I'll end up doing either a yoga class, an exercise class, or meditation.
Cool.
So it's kind of nice to have it all in one place, and then I also have the opportunity, although I probably need to do it a little more often, doing some massage. I see my chiropractor weekly, so I didn't really know, because I'm new to working with a lot of different integrative practitioners, and found out that chiropractic actually helps the immune system, and there was just a recent article showing that it improves brain function. So I was like, I see her once a week. So
that's cool. That's really good. Now, you mentioned you sleep in a little bit. Is this till like 8?
Yeah.
Or, okay.
Well, I guess that's sleeping in, but
right.
So I get up around 8 and I start work around 9:15. So,
yeah, perfect.
So not too bad. And then unfortunately with this clinic, just growing, I'm working later, but again, my goal is to get everything working and that I can enjoy my life.
Absolutely. That work-life balance you're trying
Correct.
to optimize at this
right.
point. Yeah.
Because I always say, I built this clinic to help everybody else, but I'm killing myself in between. But no, so I basically learned, I take certain supplements that make me feel better, incorporating exercise. I practice what I preach, A lot of my patients say, I'll do whatever you're doing.
That's awesome. Yeah, you need to be the change that you want to see in the world, right? Which is really important. So you mentioned supplements. That's the next question. If there was really one herb, nutrient, botanical, or just food substance, maybe kombucha, green tea, that you just couldn't live without, and there's 2 of them that are already covered, vitamin D and omega-3 fats, because everyone talks about that.
Right.
What else could you not live without?
I basically, I use like a methylator product. So basically B vitamins is specifically with B12. So I think that for me is like, I find B vitamins huge benefit to the practice. I always go, okay, what do B vitamins do? So they help with fat and carb metabolism, they help with methylation, the energy, they're part of the Krebs cycle, they help with neurotransmitters, they help with the immune system, they help with methylation and detoxification. Sounds pretty good to me.
Right. Plus, a lot of foods now don't have a lot of, the nutrient content in food is going down over time, right?
Right.
Good point. So methyl B12, methylfolate, B6.
B12.
Those are your big guys?
Yeah.
Awesome. And they're good, like you mentioned, in that hormone metabolic pathway is really important, yeah?
Yep.
Yeah. So final question here. If you were to bump shoulders with someone from the World Health Organization, maybe a Prime Minister of Canada, future President of the US, and had 30 seconds to share with them just one lifestyle or health tip that you would want them to know, maybe they could influence policy around or just mull over in their head, what would you want them to know? What would come to mind?
That they need to spend their healthcare dollars differently. Right now they're cutting dollars on testing and saying we need to choose wisely our tests and choose less. And I think it's totally the opposite. I think we need to do more testing to find those deficiencies and correct them. In the long run, they're going to save more money because the population will be healthier.
Right. So what you're seeing is...
well, they're telling us don't order B12s. No one's B12 deficient. Really? Because I see tons of B12 deficient. Oh, don't order magnesium. I see tons of magnesium deficiency. Magnesium deficiency relates to insulin resistance and, anxiety, sleep problems, whatever. So I actually think that testing is important because it helps target those supplements or treatment plan.
Which, if left unaddressed, would manifest into more complicated diseases
Chronic
that will cost
disease,
much more.
Yeah.
Yeah, I did lab work about 2 weeks ago, and my practitioner that I work with, she's like, yeah, Mike, insurance companies aren't covering vitamin D anymore. I'm like, what? Are you kidding me? Like, all the data has emerged in the last 10 years about vitamin D. She's like, yeah, I know, it's crazy. It's just a new thing. So just be prepared. You're going to probably pay out of pocket. I'm like, $100, I don't really care. But I thought I was really shocked by that.
No, it's crazy. No, they're saying, oh, we shouldn't be bothering testing, and there's more and more data saying that it should.
Well, good piece of advice. Hopefully people will listen and share that message. So Dr. Caplan, I really appreciate you sharing all this wonderful information. Appreciate you taking the time. I know you're very busy. If folks want to reach out to you, connect with you, become a patient, learn more about your work, where can they find you online?
So vitalitymd.com is a nice, easy website, and there's a lot of information on the web. We're located in Toronto on Avenue Road, and our phone number, 416-792-1100.
Fantastic. Well, again, I really appreciate you coming on the show. Folks, if you want to check out the show notes, you can click the link below this video and also on our blog at highintensityhealth.com. So thanks again. This was a lot of fun.
Thank you.
Appreciate it.